Microphone, is it in?
Hello, can you hear me?
Yeah. Okay. Hello, good morning everybody. I'm glad to introduce this Biotech Innovation session. I would like to welcome to Dr. Sri Ganesh that talks us about the yacht from Femtosecond lens surgery with an HAPTIC toric yacht.
Thank you very much. Good afternoon, everybody. And I would like to present my design of the SWIVEL HAPTIC toric IOL for femtosecond laser cataract surgery. I am a consultant to Carl Zeiss Meditech and Biotech Vision, and I designed this lens, and right now we have this lens along with Biotech, and I'll be sharing the presentation on this lens. Go ahead. So if you look at capsulotomy fixated lenses and what is available in the market, basically if you look at lenses today, you have some issues, common pitfalls. One is the effective lens position is not very predictable, and that's why you can have refractive surprises. Rotational stability for toric IOLs again can be an issue, especially in larger bags where the lens tends to rotate, and then you have post-op residual cylinders. If you have complications like PC rent, then you cannot use premium or toric IOLs. You will have to put a 3-piece monofocal IOL, and again the patient is disappointed. You don't have any premium IOLs for aphakia. Suppose the patient is aphakic and wants a trifocal lens or a toric lens, then you don't have an option. And in today's trifocal lenses and multifocal lenses, you have a lot of rings which give rise to photic phenomenon and patient dissatisfaction. So that's a problem in today's lens design. You have the existing capsulotomy fixated IOL designs. The first one was the Moderator IOL, which needed a perfect capsulorhexis, and it's difficult to fixate. You need a perfect 4.8 mm rhexis, and for the bag in the lens IOL, you need a posterior rhexis, which is again difficult to make, and then it needs a higher degree of skill. You have the Masket IOL type 90S from Moderator. Sometimes you can have failure to capture this lens in the capsulotomy, and even you have complications of capsular blockade, and you need a perfect 4.8 mm rhexis for this lens. You need a femtosecond laser. So that's why it didn't become very popular. The most popular lens today is the Femtis IOL, which is a capsulotomy fixated lenses. It is a hydrophilic lens, again complex design, and this is one of my surgeries where I'm using the Femtis. Again, it is difficult to capture. You need a perfect rhexis, so you need a femtosecond laser, and you need to capture this in the capsulotomy, and a little more maneuvers, technically a little more difficult. And once you capture this also, then removing the viscoelastic from behind the lens is difficult, so you need to actually capture the IOL after removing the viscoelastic under BSS, which is again a challenge. So these are few. While doing the IA, you cannot remove the viscoelastic from behind the lens. So I got an idea for a capsulotomy fixated IOL when I was riding my motorcycle, and I just put in the stand. So then I had an idea, why not use a swivel haptic which goes over the capsulotomy and fixate it. So it's a very simple idea, and so we have this toric design now. So we had the first designs of the swivel haptics which we implanted. Now it's a single piece C-loop lens, toric, but it has got two swivel haptics which swivel so that it can capture the capsulotomy. Overall diameter is 6 millimeter, optic diameter 6 millimeter, overall diameter is 13 millimeters, 360 degrees square edge. So next, let's look at some cases. One is an uneventful case. So this is, you can see a femto capsulotomy with the lens AR, and this is the swivel haptic IOL. Those are the two swivels. You load it into the cartridge as you do a regular lens. You don't need any complex injectors. You can use your regular cartridge and injector, and then you inject the lens into the capsular bag, rotate it, and then you can capture the, you swivel the haptics over the anterior capsule and you capture the capsulotomy. You can go underneath and remove the viscoelastic, so you can clear the viscoelastic very easily, and you can place it on axis. Once it's captured, there is no rotation at all, and you can see your intended axis was 104 degrees. It's perfect, and post-op refraction plano 6.6. So this is an example of a regular case with a femto cataract. Now let's look at a manual capsulorhexis. This was a femto capsulotomy, which again the patient moved the eye. So we had to do complete it with the forceps, and you can see the rhexis is not perfect. It's not a perfect 4.8 mm rhexis. It's slightly larger, but even in this case, you are able to capture the capsulotomy, because unlike the femtis or the Morcher lens, you don't need a 360 degree perfect capsulotomy. Even with a manual rhexis, you can still use it, and it works well. Now let's look at another case scenario when you have a PC rent. Normally when you have a PC rent, you have to have a standby 3-piece lens. Here you can see there's a large PCR, but in spite of the PC rent, I'm using this lens. And what I do is I use the swivel haptic, capture it, place it on axis, and then tuck in the haptics under the anterior capsule. So you can see that it's a toric lens. You're using a toric lens. Even in the case of a PCR, you're able to align it perfectly on axis, and you don't have any rotation. You don't have to have a standby lens. So the same lens works even if you have a PCR. Let's look at another scenario, which is aphakia. You can use this for scleral fixation also. So this is a aphakia with a cylinder, corneal astigmatism. So here we are actually marking, we have a markerless system, and then I go in and through a 2.8 mm inject the lens. You can see the swivel haptics has holes there. So I'm going to use this and flange it exactly 90 degrees to the axis. I preload a 27 gauge needle with 6-O-proline, pass it through the swivel haptic, flange it, and then put it under the iris. And then again go to the opposite side, 1.7 millimeters from the limbus. I just insert the needle with the proline, preloaded proline, and then I flange it, and there you're able to use this lens even a case of aphakia with no capsular bag, and you can see that it's placed on axis, so you can correct astigmatism also. You can use premium lenses even when you want to treat aphakia. So that's the external flange for scleral fixation, and then you can see that it's on axis. So you can get a very good refractive result even in cases of aphakia. Let's look at this case, extreme Marfan syndrome, extreme subluxation, 2 diopters of astigmatism. So here I'm going to remove this lens, because again with ectopia lentis you have progressive subluxation. So if you put a toric lens in the bag, even with a CTR and a CTS, over a period of time there can be progression of the subluxation. So here I am removing the soft nucleus. I remove the entire bag, though I have a capsulorhexis. The bag is very weak, 270 degrees of subluxation. I remove the capsular bag, I do an anterior vitrectomy, and then I'm able to use this SWIVEL HAPTIC TORIC IOL for scleral fixation. Load it into the injector, inject it into the anterior chamber, and then I'm passing the needle with the proline, take out the 6-proline, pass it from above, below, through the SWIVEL HAPTIC, bring it out of the wound, flange it, and do the same thing for the other side. So you have to enter exactly 90 degrees to the axis for flanging, and then you do the external flanges, and you can see the pupil has constricted, but it doesn't matter, you can still go ahead, and you can see it's on axis. So even in such complex cases you can use the same lens. There is no need for a standby lens. You can use a toric IOL even for a regular lens. The stability is very good. So why use this lens? Sorry. So why use this lens? It has got a lot of advantages. One is rotational stability is perfect. It does not rotate for toric IOLs. You can use it either with a manual capsulotomy or a femtocapsulotomy. You have better centration, less tilt because it's fixated to the capsulotomy, no special instruments or special training required. It's got a relatively anterior and fixed ELP, so you don't have refractive surprises. It has no negative dysphotopsia because it's more anterior. You can use it even if you have a PC rent with an intact rhexis. You can use it for scleral fixation. Even in case of zonular dehiscence, you can use it. So the future is, of course, near ad. You need, because of the anterior ELP, the near ad requirement is reduced, or less number of rings. IOL can be centered to the visual axis if you make the femtocapsulotomy along the visual axis in large angle alpha. So large angle alpha is no longer a contraindication for multifocal or trifocal IOLs. So you can have it in various designs: monofocal, stable toric IOLs, multifocal, trifocal lenses. Even you can use it in large angle kappas. You can use it if you have a PC rent and vitreous loss. You can also use it in aphakia or zonular dehiscence. So it is one lens for all seasons and all reasons. So this is a new innovation which I have designed along with Biotech, and we are working for commercial approval, and shortly it should be available to most of you all. Thank you very much, and if you have any questions, happy to take them.
This device is always movable also.
Yes.
So actually, also if you have to expand the lens,
It's quite easy.
you can close it.
You can close it and expand.
Okay, thank you very much.
Are there any questions? Okay, thank you very much.
Thank you,
Ganesh,
thank you.
and congratulations.
Thank you. Thank you.
Very nice
Thank you.
presentation,
Thank you.
sir. Yeah.
Thank you.
Thank you.
Thank you. Hello, Mamta. How are you?
How are you?
Good, good, good.
Prepara
So
di
good to
domani.
see you. I was just